Good afternoon, everybody. It's a real pleasure to start our grand rounds on diversity, equity, and inclusion, and to have an amazing and outstanding colleague, friend, Dr. Tracey Henry, with us today. I really appreciate the time that all of you are taking for this important topic. This is the first grand round, but a lot of more to come. This is an effort of the Committee on Diversity, Equity, and Inclusion, chaired by Dr. Ra, and really appreciate the time that you're taking, and also appreciate Leticia for organizing all of this. So let me introduce to you Dr. Tracey Henry. She's an associate professor of medicine at the Emory University School of Medicine. As a clinical educator and an attending physician, both inpatient and outpatient medicine. She's the assistant health director for the Grady Primary Care Center and co-director of the Health Equity Advocacy Policy Track for Emory GME program. Dr. Henry teaching and research interests includes healthcare advocacy and policy, healthcare equity, quality improvement and patient safety, and integrating behavioral and mental health use into primary care. Dr. Henry obtained her MD degree at George Washington University and her MPH from Johns Hopkins University. On a personal note, I work a lot with Dr. Henry in multiple organizations. Dr. Henry is a chair elect for the American College of Physicians Council of Early Career Physician. She has done a lot of work. She's also a Presidential Leadership Scholarship. She's very active in organized medicine, from her local to the American Medical Association. Right now, both of us are in Washington, D.C. in the AAMC GDI conference. So I really appreciate the time that she took from this conference to give us her presentation. Thank you so much, Dr. Henry, for being here. Thank you, everybody, for attending this. And now the floor is yours.
Wow, thank you, Dr. Correa. That's such an amazing, warm welcome, and it is definitely a pleasure for me to be here. And so let me share my screen and we will begin. Again, I am very proud to be here today and to talk to you guys about the work that I have been doing over the last year or two since the death of George Floyd. And so with that being said, the title of my discussion this afternoon is Dismantling Systemic Racism, One Step at a Time Through Advocacy. Disclosures, I have no financial conflicts to disclose. Our objectives this afternoon would be to briefly review the history of systemic racism in the United States, discuss my experience in DEI work and in dismantling systemic racism, and then finally to review best practices to start dismantling systemic racism through advocacy. So I like to begin at the beginning, and I always like to make sure that we're all on the same page. With that said, language matters, so let's review a few key terms. And those would be race, racism, implicit bias, health disparities, equity and equality, cultural competency versus cultural humility, and structural competency. I hear a lot of my colleagues, my learners use these terms, and even people outside of the medical field, they're always like, oh, aren't they the same thing? When I hear one, isn't it all, are we all talking about the same thing? And so I definitely like to start off with making sure we're on the same page. And so race is a social construct. There's no biological basis for race. It's simply a way of categorizing groups of people, and often to explain, justify, or even maintain the inequities and oppressive social practices that we see often in the United States. And it has varied over time and changed over time. And what I mean by that, if you go back through the decades, in the 1960s, you have been the race of the person who knocked on your door. In the 70s, you were your dad's race. In the 80s, your mom's race. And in the 90s, and there was the opportunity to choose one or more races. And so that it really has changed over time, and in other countries and parts of the world. Here in America, I am Black or African American, but in other places, I may be considered another race. And racism versus implicit bias. And I like this definition from Dr. Kamara Jones, and she was actually the president of the APHA, the Public Health Association. And she's been talking about this for a long time, and she published on this back in 2000, so over 2 decades ago. And she says, racism is a system of structuring opportunities and assigning value based on the social interpretation of how one looks. And it unfairly disadvantages some individuals and communities, and then unfairly advantages others. And it also just saps the strength of the whole society through the waste of human resources. And then versus implicit bias is so like the term implicit, and previously we used to call this unconscious bias, but more so moved on to saying it's implicit, but it's a process of associating stereotypes or attitudes towards categories of people without our conscious awareness. And the way I like to think of it is these are these mental shortcuts that we have. Sometimes our brain, we could be a little lazy, and we want to quickly get to or identify or summarize what we're thinking. And the way we do that is through mental shortcuts. And that's what those sort of biases are, how we unconsciously group people into these categories. So systemic versus structural racism. I hear that all the time. I mean, ultimately, right, they're used interchangeably, but systemic racism really is the term that we've moved towards because it really highlights the pervasiveness of racism versus, and I think it's systemic, like a disease that's systemic. It's septic, how the blood infection can go throughout your entire body. But it's just like sepsis, where blood infection can actually permeate throughout your entire body. That's the same way as why we refer to it as systemic racism versus structural racism. Even though right now they're sort of used interchangeably, it's really those actual policies and practices that are in place that continue to perpetuate those inequities. And I like to think of it, basically systemic versus structural versus institutional racism as the spider web on the screen. So this entire spider web itself is the system, is racism. And then structural will be all the different points where the lines intersect. And then institutional are the little webbings going throughout that are in different medical institutions or the incarceration or prison institution or educational institutions. And then equity versus disparities. Equity is when everyone has the opportunity to be as healthy as possible, and we're not all, and it's getting what you need, not everyone getting the same thing, which will be equality. And disparities are just those differences in healthcare. And inequity, I like to take a further step, is that when we see in health inequity versus the disparities being the difference, the inequity part is that not only are there differences, but there are differences that are unjust, that are avoidable or could have been preventable. And then, I hear a lot of cultural competency versus humility. The better term that we've moved towards is humility. And the reason why is that competency is basically saying that it's a distinct endpoint and assumes that there's no more learning or engagement needed. I've learned what I need to know. I've checked my boxes. I know how to talk to this type of patient. I know how to talk to this patient of this different background and culture, so I'm good. And humility is really saying that we're open, we're self-aware, we set aside our egos, we self-reflect, and it's lifelong. It's an active process. We can never know everything about everyone. We all have our different intersecting identities. And so there's no way to say that, oh, I've learned how to talk with this population, that I know how to practice cultural sensitive care with everyone. So that's why we say cultural humility, which is, a lifelong active process. And I thought I'd throw this in, just the structural competency. I hear a lot of this, and people always ask me, what does this really mean? I mean, all of these words, they all sound so similar. But really it's just saying that structural competency, it recognizes that the structures in healthcare, like laws or policies that affect medical education, in health and our clinical interactions with patients and populations, are really the result of a wider upstream force that governs our clinical work, such as the social determinants. And so, and it moves beyond saying things are cultural competent, because cultural competency, again, it reinforces sort of these negative stereotypes, but it also is saying that we need to transform medical education to include it in the curriculum. We should be talking about health equity. We should talk about social determinants of health in the medical education setting. And this is actually a picture, maybe this make it a little bit easier to grasp, but it's from a book back in, I think this is a Structural Competency Working Group. Basically you see the structures on the left, and because of these structures, we have all these policies, economic system, social hierarchies, for example, racism, that perpetuate it's inequality here, but really the inequities we see in healthcare and health disparities. And the idea is that we should change med-ed to address these things. All right, so now that we have the definitions down, I'd like to just briefly walk you through a history of racism in the United States, because in order to really understand, you have to acknowledge its timeline. And so if you think about the United States, way back in the beginning, in 1607, when the first set of settlers came to Jamestown, Virginia, and then the first set of slaves came in 1619. That's why you hear a lot of people talk about the 1619 Project. Or when you heard people say, COVID-19, and then they also was referencing, the 1619. Well, that was the date that is recorded in history when the first set of slaves came over. And so when that happened, slavery lasted about 246 years into 1865. That's about 61% of American history. So once you just kind of take that in, 61% of our history. And then we had this brief period of the Reconstruction era where Blacks were actually in the South, were able to own land, they were able to own property, and sort of made a come up, once there was some end of slavery. But in 1877, came near slavery, or basically slavery almost, was the Jim Crow segregation, which was another 91 years. And that ended in 1968. So just looking at the screen now, you got slavery, 61% of history. Then you have this brief moment of the Reconstructive period. Then you have another 23% of Jim Crow and segregation, which is another 91 years. And which all ended, beginning first with the Brown versus Board of Education in 1954, Civil Rights Act of 64, Voting Rights Act of 65, and Civil Rights Act of 1968. So here we are, we're actually now 2022, but very close. So looking here, only 13% of US history have we been free. And many would say a lot of racial ethnic minorities are still not free in America because of racism. And so when you think about why racism permeates throughout everything in the United States, it's because this is really all we've known. In the United States, it's the only industrialized country to have built its wealth and has built up their country based on slavery. And thus, this is by Dr. Paul Batalden. Every system is perfectly designed to get the results it gets. And just more data. I know, for Grand Rounds, we love to see data, right? And so this is American College of Physicians, for which I am a member of. And we have several papers where it was heavily researched, where we discuss a lot of the problems in health and healthcare and racism and all of the different inequities, and made several recommendations of how we can mitigate a lot of what we see currently in health and healthcare. In Annals of Internal Medicine, the MCAT's restrictive effect on minority physician pipelines, a legal perspective. We've seen how race and ethnic health disparities related to COVID-19, New England Journal of Medicine, misrepresenting race, the role of medical schools in propagating bias. So there's tons of ideas, opinions, there's research and actual data to show the problem of disparities, the problem of racism and health and healthcare in the United States. We even see this on the CDC and differences between whites and Blacks and other racial ethnic minorities, and breast cancer incidence and mortality. Bias and pain assessment. We're all familiar with this study where they interviewed or surveyed medical students, and the thought process was that they thought Black Americans actually do not feel pain as much as white Americans because their skin was thicker and they had less pain receptors in their skin, which is not true. We saw the consequences of structural racism on MCAT scores and admissions, the allostatic load or wear and tear on our bodies that affect patients who are experiencing racial inequities and disparities. And then really it just goes on. And so moving on to the second part of my talk this afternoon is really about my experience in DEI and dismantling systemic racism. And really the hope is to show you how one person can make a difference. During COVID, I was pretty much on service every single month of COVID. And actually didn't get my vacation till the following year, just because of COVID and a lot of, you know how things were going. But that saying, I'm a basic clinician, have a family and all these things, but I did see a lot of things that kept me up at night, things I did not like seeing in healthcare, things I didn't like in my community and in the society. And so I wanted to make a difference. And so hopefully I inspire you guys to say, one person can make a difference in your sphere of influence based on your interests and things that you're seeing and things that are keeping you up at night. And so I actually decided to bucket the things that I was doing in 2020 and 2021 into workforce, access, and research as it relates to health. And my work in STEM stemmed from my roots in advocacy. This is one of my advocacy days a few years ago, pre-COVID. And in order to be effective, I really feel we have to be committed to some form of advocacy, and we'll go through, there's different levels of advocacy. And my particular, my journey and everyone's journey, it's of 1,000 miles, but it really begins with one step. And all that to say is that we can all do it. And I really am just going to walk you through, what I've been doing. All right, and just everything stems from equity. In DEI, I always love to lead with equity, because if you really strive for equity, you'll end up with diverse, you end up with inclusiveness, and then eventually belonging. So these are the levels of racism, a theoretical framework. So again, Dr. Kamara Jones published on this in 2000, and she called it internalized racism, personally mediated racism, and institutionalized racism. So this was a term used in 2000. Over time, as I've said, the term institutional racism, structural, systemic have really varied over time and sort of evolved in their definitions. So I specifically use this socio-ecological model in individual, interpersonal, institutional, community, and national legislative to describe the work I've been doing. So from a national legislative level, I actually did quite a bit of advocacy, and this was the year of COVID. Probably literally we learned about COVID and shut down a couple weeks later, but we were at the Capitol. I was with students. Georgia is, depending on the year, where we rank last in terms of maternal mortality, or second to last, or third to last, but we're somewhere near the bottom. And we have over 50, 60 counties in the state of Georgia without an OBGYN. And so we actually were advocating for extension of Medicaid to cover women in the postpartum period from 3 months to 6 months, which successfully passed actually that year. And of note, this year, we're actually working to expand Medicaid from 6 months to a year. So we hopefully will be successful in that as well. I don't want you to sleep on advocacy, legislative advocacy. Some people are afraid of it and think, oh my gosh, I could never see myself talking to a legislator. But policy is a lot of times the way to go, top down. And so this is an example here of how the federal government used Title VI, Title VI, and actually, Title VI and actually Title VII of Medicare to racially integrate hospitals in the United States from 1963 through 1967. And basically what the federal government did is they withheld payments to hospitals if you did not see a patient of color. And that was what led to desegregation of our hospitals from a policy legislative standpoint. And this is another example. This is one of our medical students. She's now in M3, but she did this in her M1 year. She's the president of the Student National Medical Association. She worked with her chapter, the Morehouse School of Medicine chapter in Atlanta, Georgia, and also students from other affinity groups, and then eventually most of the students in the class. And what was great about this effort is that they were all busy students. There were a lot of protests that were happening in downtown Atlanta at this time, but they wanted to do something, they wanted to have an impact, and they wanted to make a difference. And so what they did is they got together and said, I want to say, because we're busy, they got to study, and they couldn't, spend a whole lot of time doing lots of things. So they said, I would like to write a resolution declaring racism as a public health crisis. And when they did that, they wanted to make sure they had the support of the medical community at large. And they actually started a petition, and they had almost 6,600 medical folks in our community in Atlanta metro area to sign this petition stating racism is a public health crisis. And also to inform their health policy brief, they wrote their resolution, they wrote a brief on the disparities that exist in Atlanta metro area. And so they used a lot of this data to inform the actual resolution here that you see on the screen. DeKalb County is where Emory University is located. So they did the petition showing they had all these folks on board. Then they wrote a brief to get all the data, get their language together, and they used that to inform what they wrote in the resolution. And then in July 2020, the arrow there is the Jasmine Eatman, who was the president of SNMA at that time. She presented the resolution before the DeKalb County commissioners, and it was unanimous vote to declare racism as a public health crisis. And this was in July 14, 2020. And then, made the local newspapers and our local magazines. And at that time in 2020, there was very few municipalities that declared racism as a public health crisis. Very few. So you might be thinking, oh, what's the big deal? But actually to date, there have been, I think, over about 210, 220 counties or cities or state legislators who declared it. But at that time, I think we were probably less than 20. So we really were one of the earlier adopters. And then so from a community level, I participated in quite a bit of town halls during that time. Since we were shut down for a period and, there was very little going out. So we went to where the people were. We had community town halls on Facebook where we had really large attendance. We also did town halls with Mental Health America Georgia, and making sure that we had resources for patients with COVID and families of patients with COVID and patients with mental health disorders with also COVID-19 and needed assistance during that time. We also had peaceful demonstrations, White Coats for Black Lives. A lot of universities did this across the United States, and we were no different. That's me over there in the corner. Institutional-wise, we started doing these anti-racism diversity dialogues, which was really just providing a safe and brave space for discussions about race and internal reflection, but not just we actively listen, but not just listen, but we tried to learn, and also had action-focused opportunities where we move things and we actually made recommendations that we implemented to make our workspace better. This is me in the announcement. We also wrote a proposal with the students to have a DEI and racial advocacy or anti-racism curriculum, and I'm their new thread director. And what's different about our curriculum is we've made it a thread, and the thread just means that it's threaded throughout the entire 4-year experience for the medical students. So as soon as they hit the door until they graduate, instead of it just being a one-off course or lecture or workshop, we are weaving in race, ethnicity appropriately, and reviewing also the curriculum as well. We're reviewing the curriculum for bias. And we're also reviewing the entire 4-year curriculum, where we're offering actual content that we should have at different points throughout the career and actually in different parts of the lectures. So it is a long process, but we really hope at the end that it could be a cohesive curriculum where students aren't thinking this is just something one-off that I have to learn, but it's not a part of my regular studying. And this is just an example of all the different things here that we're doing on the side. In addition to sort of the educational things, we're making sure everybody undergoes implicit bias training as well as upstander training. And with a bias reporting system and faculty development. Another program that I actually implemented is called Impact. And the purpose is to address the unique needs of underrepresented students who identify as underrepresented in medicine, and also to foster a sense of community and a supportive learning environment. We do a ton of things like microaggressions and bystander training, maintaining wellness, overcome the imposter phenomenon, CV building workshop. We also just had a talk 2 nights ago about being Latinx in medicine. So we do have lots of different talks and activities. And what we've learned in our first year is that a lot of what we were doing made some impact. Our mentees had a statistically significant difference in feeling more ready to handle their clinical rotations at the end of our first year in our pilot program. The feelings of needing to have an advocate went down from 85 to 47% because they felt like they had that strong social support in our mentoring program, since it was a structured mentoring program. Having insight of day-to-day activities and attending went up, and having a sense of community went up as well. And of note, our mentors, who were not really as aware of imposter phenomenon like our students, they went from 70 to 100%, but once they understood what imposter phenomenon were, they felt like they had imposter syndrome. And we think that is a lot of our mentors are, or all of them are persons of color and early career faculty who are likely experiencing some of the same things early in their career that our students are feeling. And so there was actually a sort of symbiotic relationship where they were actually benefiting from the mentoring program and the sessions as well. Another thing we did during this past year in a form of advocacy was racism and bias in medicine infographics. So a lot of the different studies that were out there, we wanted to make it clear and easy for other medical students, for laypersons. We tweeted these out once they became available. And so we basically broke down the article and put it in this form where lay people can understand it, as well as the students, colleagues, and faculty. Another project that I worked with my internal medicine residency program was something called the Health Justice Standards. And it's basically a framework for creating a more just and equitable healthcare system. And it's on our Emory Internal Medicine website. It was published a few months ago, but we started working on this in 2020 and 2021. And we found we were able to get it published earlier this year, or either late last year. And basically it's 17 standards falling in within the buckets we see here that we said we want to change about our residency program. And really, honestly, any GME program could benefit from this sort of structure. So changing the representation, the support, education, patient care, and research. Another, in terms of research things I've been working on, I'm part of our Department of Medicine DEI committee and the research subcommittee. And we were making changes, making awareness of, there's things called a diversity supplement. We're just really increasing the opportunity for more racial ethnic minorities to get involved in research, interviewing, and not actually interviewing, but surveying current researchers, those with R01 funding and other funding that you can use to do the diversity supplement in other ways, and really linking people up that are interested in research, but just not sure how to get started. So we're paving a way from that, so that in box B on the left-hand side, you see people, you know, the applicants, you see people exiting academia, but what we really want is on the right side, if we had racial equity and funding. So we want anti-racist reviewers, we want equity policies, we want more funding to health disparities research. There's a lot of studies out there. If you look at the different NIH institutions, there's institutions that get a lot of money, there's institutions that do not get as much money. And then if you look at a word cloud of the key terms that are likely to be funded, they usually have, usually it's not disparities, inequities, race, or anything that is related to those topics. This is more of the mentorship and networking that we're doing for our faculty. And this slide is really just to point out that the NIH is committed now to ending structural racism in research. And what we're doing specifically, again, these are the things I just mentioned. We have works in progress now. We have research mentor mixers. We have a new URM research award. We are investing time in URM faculty to develop grant writing skills, and then incentives for funded researchers to invest in pipeline programs. Interpersonally, things that I have been working on. This is actually from the Smithsonian, has this sort of anti-racism way of calling it out and language, and I highlighted a few here, but we did a lot of this in the beginning with our learners, with each other. If you hear something, don't be afraid to call it out, seek clarity, offer an alternative perspective. Have you considered X? Or speak your truth. I don't see it the way you do. I see it as this. Or maybe finding common ground, like we don't agree on this, but we can agree on such and such. Or maybe sometimes you just have to set boundaries when it comes to racism, right? You just say, please do not say this, or say whatever it is that is racist, or again, to me or around me. So you just have to sort of stand your ground and set boundaries. But it's nice to have template language, things to say that you can practice, so that when you do hear things, sometimes if you're so stunned, you're not sure what to say, and you may not be as quick on your feet, but if you've practiced these things, you are able and more likely empowered to intervene. And then finally, from an individual advocacy standpoint, I, again, worked with my residents and also myself. We wrote something in the SGIM forum called Draining the Pool, Our Collective Responsibility to End Racism in Medicine. We said that we need to retire the physician as hero. This narrative lets us substitute feel-good stories about helping one patient for a long-term advocacy and systemic change. If we can move beyond our lone hero complexes to join together, and if we can be imaginative and brave enough to envision and advocate for something better, we believe we can build a system we all hope to work within when we decided to become doctors. I also wrote several op-eds. These were in the Atlanta Journal Constitution. So learning from the pandemics of COVID-19 and racism. Also wrote one for Kevin MD about how educational curricular policies and parenting, how we can support anti-racism beginning in preschool. Oh, and this is one on Medicaid expansion. As you know, Georgia has not expanded Medicaid and we keep turning it down. So this was one towards the end of our legislative session to hopefully have another push for expanding Medicaid. So other considerations as it relates to racism and dismantling it, systemic racism. So really, I like to say we need more than IAT, and IAT is an implicit association test. We need more than implicit bias training. And the effects of the implicit bias training are really short-lived. But what sustains what we learn, so what I mean by that is sometimes people may do a 1-hour workshop on implicit bias training. They might do 4 hours or a full day, or they might be like Starbucks, where they closed down for several days and had some workshops and in-house. So how long is enough? And we don't know how long is enough, but we do know it's short-lived and not sustaining. But what sustains us is open, equitable attitudes and behavioral change, are connections and relationships with diverse people and lived experiences. So really it's the connections, it's relationships with people of different cultures and lived experiences that will sustain us. And also we have to be disruptive. And I like to stop and think, so how do you get a nail through an ice cube? How do you get a nail through an ice cube? Well, this is a nail trying to go through an ice cube, and the ice cube exploded. So how do you get a nail through an ice cube? And it's through constant pressure. Otherwise, you would destroy it. And that constant pressure equals relationships. So again, if we want to be disruptive, if we want to change hearts and minds, It's not just implicit bias training. We need it. We need implicit bias training because these are our biases that we all have. I have them, everyone has them, that are implicit or unconscious, right? We don't know that we have them, but when we do the training, we're hoping to uncover them and unpack them so that we can start addressing them. So we can go, oh yeah, I have a bias towards X. I've heard someone say I had a bias towards people with obesity. So when I round, I make sure to round on my patient that was obese first versus last, so that I don't not spend a lot of time on that patient, and that patient ends up with not the best care because they knew that they had sort of this averse sort of feeling with the patient who had obesity. Another program that I've done that I like to point out is the Presidential Leadership Scholars Program. And we had a lot of lessons, but one of the lessons that I wanted to share with you today in reference to this talk is the lesson in finding commonality. There were 60 of us scholars a year. And again, talking about changing hearts and minds. The first assignment in my year, in the third cohort, was to actually act as if we have known each other for 10 years. And I don't know how often you guys do that. A lot of us play coy, we keep to ourselves, we're very reserved, we like to try to get to see who people are first. But since it was a very brief program and we're together sometimes only for 3 days a month, then we really had to make the most of our time. And so you didn't have time to play coy, but really just to get in there and start acting, doing what you would do if had you known this person for 10 years. And because of that, we were challenged to disagree with each other, to rank our values. We were asked to defend our positions. We discussed criminal justice reform, mass incarceration, welfare reform, economic policy, abortion, human rights, all these issues that typically divide our country. And throughout the week, we held conversations that we would otherwise try to avoid. And ultimately, it was our differences that joined us and attracted us to each other while building a stronger bond as each day passed. And actually, these are some pictures of myself and other co-scholars. And in the end, our racial, religious, political, socioeconomic identities all took a backseat. So we came in very different and from all walks of lives, but it all took a backseat to our relationship building and our desire to prioritize civility and finding common ground. And we really did that. So it didn't matter. We support each other's campaigns, whether we're liberal or conservative, we support each other. We support each other's and our families and jobs and whatever we're doing, wherever we can. And it was a really amazing example of it, all these religious things and partisan things that divide us in our country really do not have to do that. And that's me there. All right, so what does the evidence suggest? This is a grand rounds, we love evidence. And so I put a whole bunch of different references here in the slide. And it says basically that implicit bias training and relationship building actually can increase internal intrinsic motivation. It increases cognitive empathy, it increases emotional regulation skills, and this sort of common in-group identity by having partnership relationship building. So relationship building actually does something. Empathy and perspective taking skills. You get perspective taking skills. The cognitive component of empathy has been shown to inhibit the activation of all these unconscious stereotypes and biases and prejudices. And it also, again, increases both individualization and sense of commonality. And then the relationship building piece, basically, again, I'm doing this being iterative and duplicative on purpose, is that it mitigates the likelihood of implicit bias on our behaviors. And so once it does all these things, it's in-group identity, we have better perceptions of each other, and you're able to have stronger bonds and commonality within group settings. And so finally getting to dismantling racism, and I just want to point out by Thomas Edison, vision without execution is hallucination. So, we may have a ton of ideas, racism may really bother us, but without a plan and without executing them, it's really just, a thought in your head. And so some pro tips for dismantling systemic racism. We really have to have a commitment to action. We need to be mission driven. You need a leader to drive cultural change. You need to know our history, which is what we talked very briefly about today. And we want to be transformative and not performative. A lot of what has been done in the last several years have been checkbox. It's did we do X, Y, and Z? We have this person in place. We're diverse, but you're diverse without equity, you're diverse without inclusiveness, and without belonging. Another set of dismantling pro tips is avoid individualizing or blaming patients. So in the patient setting, we can get really upset. Sometimes if you're working at a county hospital or safety net hospital where you train, you can get really upset and start blaming the patient for issues that are really structural and systemic, like I mentioned at the beginning of this talk. You can perpetuate racist stereotypes. When we bring our individual interpersonal biases and racism to these systemic processes, we get this Swiss cheese model of bad things and bad outcomes that can happen to the patient. So the system is dysfunctional, then you have your biases, and then that leads to poor health outcomes. And we have to start questioning the practices that we were taught. And a great example of that was students at Harvard who actually started questioning about all those different clinical algorithms. And then as you saw later on, that paper in New England Journal of Medicine that was hidden in plain sight, where it really discussed all the problems like the EGFR calculator, VBAC calculator, PFTs, et cetera. And so really that just came with people thinking about, this doesn't make sense. If race is a social construct, then why do we have these certain things and race in these clinical algorithms? And in patient care, I like to say, within our diagnostic and reasoning plan and deciding care for patients, we really have to start asking these questions. And these are more of an equity check. Why are we choosing this intervention for a patient? Did this deviate from the standard of care? How so and why? I think Harvard was also the same place that had these two different services. So they had this one service where they went to a teaching team, the other went to a chest pain team. And they noticed that the ones that went to actually cardiology team, there were better health outcomes than the ones that went to the teaching team. So why are some patients only seen by teaching teams, and why and get a different set of care than the ones that are by attending only teams or mixed teams? And so you just have to start asking these questions, the how and the why. And did you ask the patient for their perspective? Did you ask them what the patient want? And if the patient was you or a loved one, would you recommend the same plan? And I think that's really the litmus test there is, for each and every patient, if this was the person that you love the most, is this the recommendation you would give to that person? And you should also always speak up, the same way we did with CODIs and CLABSIs, which is those catheter-related bloodstream infections and central line associated bloodstream infections. You have to speak up when you see something impacting care. And then also in terms of scholarly, when we think about academic promotion and how the standards are for academic promotion, think about who was at the table at the time when these promotion guidelines are set. And should we change what we mean by what is academic, what is scholarly? And, thinking about redefining that. If someone on Twitter has 100,000 followers and getting all of these reads and it's reaching so many people, way more than who would have read or download the article in a peer-reviewed journal, is that not so scholarly? Are you still not getting out that message? Are you still not educating the public and your peers? And so we really have to start thinking about what we consider to be scholarly. And in our abstract competition, start adding an equity category. We at Emory have something called Health Equity Day and also Health Equity Rounds, which is basically like the old morbidity and mortality conferences where you talk about, all the things that went wrong in a patient's care that led to the adverse outcome. But what about the things that are related to equity or inequities in care that also led to adverse outcomes? But then we also end it with improvement, which is, what can we do to make change or interventions that could mitigate this from happening again? Other pro tips is, raise concerns. Just like I said before, you really have to realize that racism, through a patient safety mechanism, as it is a patient safety issue. So the things that happens to our patients that are inequitable in healthcare is a patient safety issue. The delayed care, track health equity, root cause analysis, empower your team members to speak up. And also model appropriate care as attendings and up-level residents. Being an ally, speaking up, not laughing at jokes that perpetuate isms, not to use these biased language. In the EHR, there's a new study in health affairs that came out in this their systemic racism special issue a couple weeks ago, and it talks about all of how the biased language in EHRs lead to poor health outcomes. And this was at the beginning of COVID in June 2020. Dr. Ibrahim, I believe is the first person who tweeted this. But this was around on Twitter and all of social media of how to become an anti-racist. But I really just like the idea of how it was grouped, fear zone, learning zone, growth zone. But we really want to be, in this growth zone where we speak out when we see racism in action, where we educate our peers how racism harms our profession, and we don't let our own mistakes, our own biases deter us from being better. So in summary, we need top-down commitment, legislative and policy changes. Because just like how Title VI of Medicare led to desegregation of hospitals, when you have that top-down, it shows really the commitment by leadership of what you need at your institution. But we also need individual and interpersonal commitment for sustainable changes. So we need at our levels individual, we need to speak out with each other so that we can move forward together in making this a better place to be and live and work, and making healthcare better. And then we also have to recognize where you are in your journey to anti-racism and intervene within your sphere of influence. You can advocate. These are the things that I've done to dismantle systemic racism, because these are my interests and within my sphere of influence. But figure out, where's yours and what can you do? Focus on equity, always start with equity, then you get diversity, you get inclusiveness, and eventually belonging is what we want. Find common ground and focus on relationships. If racism was constructed, it can be undone. It can be undone if people understand when it was constructed, why it was constructed, and how it functions and how it is maintained. And this was the Aspen Institute in 2002. This is my contact information. And healthcare, not so easy. And I open things up for question and answer.
Oh, thank you so much, Dr. Henry, for that wonderful presentation. Very enlightened on several of these topics. So I want to open the question for everybody. You can write in the chat, or you can just unmute yourself. I have one from Dr. Johnson. She's mentioned that could you please comment on the notion of the minority tax, which denotes that a few faculty of color bear the brunt of responsibility of mentoring trainees of color, serving on numerous DEI committees, and bear the responsibility of having educated our peers, while continue to experience bias and microaggression in our own work. I'm wondering if you could speak to the need to build allyship in this work, and that it be rewarded when being considered for promotion and tenure and other recognitions.
Thank you, Dr. Johnson. Very good question. Yes, the minority tax is live and well. And I think we have to just start acknowledging that. I think mentors, when I started out, I really wasn't sure. I never even heard of the minority tax, but I definitely felt it. And when I finally knew what that was, I was like, yep, I've been doing that. So, first just starting out, those who are aware of it, those who are maybe further along in their careers, mention it to their mentees, letting people know that this exists. and you do not have to volunteer for every committee. You can respectfully say, no, thank you, but you can help. You can, if they would like for you to be a part of a committee and do some work, then they will provide what we call FTE, or I hate saying protected time, but they will provide you some of the time so that you are able to contribute without necessarily it spilling over into your family time, it's spilling over into your clinical time, it's spilling over into your time you could have been doing scholarly work and things that you needed to be promoted. I think also another important piece is allyship. And I'll give you an example. So the residents who actually at my internal medicine residency program who started those standards, and it actually was through something called the CDIC Advocacy Committee. So the CDIC just stands for the Church World Diverse Inclusive Collective, which is the group of URIM residents at the residency program and also their allies. But the advocacy group was a group of a ton of allies, people who were not necessarily identifying as URIM residents. This is all during the time of right after George Floyd and all of those other killings of Black men and women, and they wanted to do something. They wanted to make a difference. And that's how the advocacy group was born. And they actually started doing all of these different talks. They got the standards together. They work with the main CDIC group, but they really were allies who wanted to make a difference and they didn't want to perpetuate the minority tax. I know it's a long answer, but you do have to have allyship. We do have to involve, it's not just for people of color to solve racism, it's for everyone to do their own homework. And not for the minority person to do the teaching.
Just following with that question, can I ask you, how do you say no when somebody, for example, and this is a problem with the minority tax, that you're certain afraid of saying no because it's your chair that is asking you? Do you have any strategy on how to say no to that kind of things?
Sometimes in saying no, I actually may say, well, so perhaps I have another colleague who is looking to get involved, and I may suggest, oh, such and such, and whether they are minority or an ally, I would just, I may say no, but I am aware that this person is very interested in this work and looking to get involved. And then that's one way of saying no, but also saying, hey, I recognize this is important, but I do not have the bandwidth at this time, but I think someone else might be interested in this role, and give the opportunity to someone else. Because we all, like to do some service, and we all want to give back, but we can't spread ourselves too thin. And there are colleagues, or some of us who may not, who want to get involved and just hadn't had opportunity. And I think it's, to Dr. Johnson's point, to always assume that all DEI roles and other roles have to be done by a person of color. There are allies out there who want to do the work as well, and we can spread the wealth, is what I like to say, and we can get others involved.
Oh, thank you so much. There was probably a question for Leticia. That's the recording is going to be shared.
Yes. Yes, the recording will be shared. I believe Jessica Seaman will allow us to do that via Jade.
Perfect. We have time for one more question. Dr. Powell said to follow up on the comment about everybody participating in DEI education as a white physician female who has worked in limited resources environment, Peace Corps, Indian Health Services, etc. I feel strongly about this, but sometimes I feel like I might overstep in my place. How would you respond to that?
Yeah, thanks. So I respond. Again, I think I mentioned that I'm the new DEI and Antiracism director for our curriculum, and I think one of my colleagues who identifies as cisgendered white male, and he is very involved in the work, very much involved, very interested, doing a lot of the reviews, education, self-learning, teaching, and how can you turn down enthusiasm? How can you turn down someone who wants to do the work and who is committed and wants to make a difference? So my answer to that is yes, get involved. You're not stepping on toes. Again, we can't do it alone. I can't do it by myself, and not any other person of color can do it by themselves. We welcome at least I can say I welcome allyship. I welcome everyone who wants to get involved in this work. And I think you shouldn't be worried about stepping on toes.
Okay, so we are at the tower. Really, first of all, appreciate your time for being here in our first inaugural DEI Grand Round. Thank you so much, Dr. Henry, for taking your time. I know you're busy in the GDI-AAMC meeting, and with that, you took the time. I see that you are in your hotel room, so thank you so much for taking the time for enlightening us with this topic, the Creighton School of Medicine, Phoenix. Thank you so much, Leticia, again, for organizing this, and the Committee on Diversity, Equity, and Inclusion. I say Dr. Pettit there for your time, and then for really starting this initiative on having some grand rounds on this topic. So it was a real pleasure, and hopefully you have a amazing rest of your day. Thank you so much.